Apex beat. What exactly does it mean? How do I locate it? What's the importance or the significance of? This is the slower version of the previous video that I did some years ago, and it's slightly slower so as to be able to appreciate the anatomy in terms of clinical significance, anatomical landmarks, how to locate and best to appreciate. So let's begin with, first and foremost, where the heart sits anatomically. It's between the second and the fifth intercostal spaces, so between ribs 2 and 5, slightly left to the mid-sternum, and that's where it sits in the mediastinum. The heart is, for each individual, approximately the size of their fist. So if you take your right hand, make a fist like so, and place it just to the left of the sternum, or the midline, that's what you'll find. So it's, one could say it's parasagittal, but ever so slightly left to the midline, like I said. In terms of the surface anatomy here, and then moving on to the apex beat, we need to understand the structures over here. So the breastbone itself is what we refer to as the sternum. It's this that we actually cut through when performing a coronary artery bypass graft, a CABG, what used to be known as open heart surgery, largely being replaced by PCI, percutaneous angiography. So PCI, percutaneous intervention, has largely replaced this when we put the stents in angioplasty on the back of angiography. The sternum, and just at the bottom of the sternum, is the xiphoid process. The xiphoid process it is that we clear when we're doing performing CPR, for example, and we teach this on BLS, basic life support, 2-finger clearance, after which you then apply your Athena, hypothena eminence on the sternum itself. What we're clearing there is the xiphoid process. So we have most inferior aspect, xiphoid process, sternum, i.e. the breastbone itself, and then just superior to the breastbone is this little notch, this little structure over here called the manubrium. The manubrium is similar to a trapezium shaped, upside down of course, and on either side of the manubrium you have the clavicle, the collarbone. Just above the manubrium is what we call the suprasternal notch. This area which kind of dips in is important in the context of respiratory examination when we assess for tracheal deviation. So from the suprasternal notch, just this little notch, this dip here, the first solid part, manubrium, and the manubrium articulates with the sternum. That's what we refer to as a manubriosternal articulation, or the manubriosternal joint. That, as you palpate inferiorly, is palpable as the most prominent structure. So as you run your fingers down, you'll feel a little kind of a ridge. That prominence is the manubriosternal angle, also referred to as the angle of Louis, spelled L-O-I-S. On my JVP video, I've demonstrated how to actually find and calculate the angle of Louis more precisely in the context of assessing the height of the JVP. So I'm not going to do that here. So manubriosternal angle, angle of Louis. This is important because when you drop laterally, you drop into a little space, and that space is between the ribs. It's the second intercostal space, because it sits between the second and the third rib, inter meaning between, costal referring to ribs, second intercostal space, and we're on the sternal edge. We'll palpate inferiorly and you'll go over a ridge, that's your third rib, fall into another groove, that's your third intercostal space, and continue down to the fifth intercostal space. Once you're in the fifth intercostal space, you then track that intercostal space laterally. And in men, you'll find you'll stop at about in line of the nipple itself. In females, for obvious reasons, this may vary. When you stop there, that's pretty much the mid-clavicular line, the line that runs halfway between your clavicle and halfway down and go all the way down to the left fifth intercostal space, mid-clavicular line. It is here where you should be able to palpate the apex of the heart. We refer to as the apex beat. Appreciate again, go back to what we said on the outset. If we use the fist as a marker, the top is the base of the heart and the bottom is the apex. Another point to note here, clinically of relevance, is the most outer surface and the most anterior surface of the heart. When looking at it, you see the right atrium. So the right side of the heart generally sits further in that direction. Going back to the apex beat, with the patient lay supine on their back, if you're unable to feel this, ask the patient to roll over to the left, and in some cases even slightly further forward. Because the heart is suspended in the mediastinum, it will actually essentially suspend slightly further forward and into your fingers. Thus, you should be able to palpate the apex beat. If despite that maneuver you're unable to palpate the apex beat at the 5th intercostal space, left mid-clavicular line, lay the patient back. And what you then do is drop into the 6th intercostal space, so drop inferiorly. And on many occasions you may have to posteriorize, so move slightly further laterally towards the mid-axillary line. So the axillary is your armpit, and you go mid-axillary line, halfway down there. So in that direction, and you may well be able to feel the apex beat there. If this is the case, then this may indicate some form of cardiomegaly, cardioheart megaly enlargement. That cardiomegaly may be due to left ventricular hypertrophy, given the location that is, because that reflects the left ventricle. In children, the normal apex beat should be palpable at the 4th intercostal space. So there's your apex beat. Now, moving on from there, while I'm here, what you can also assess for is the concept of bruise or a parasternal heave. So whilst here, we will appreciate the valves of the heart. So over here we've got the mitral valve, and then come back up to the 4th intercostal space, left sternal edge, and you'll find the tricuspid valve. And then move superiorly to the 2nd intercostal space, still left sternal edge, so we're very much on the edge of the sternum here when I say sternal edge. And here you will find the pulmonary valve, and right sternal edge, 2nd intercostal space, you will find the aortic valve. So you can go M, T, A and P in a circular direction. My teeth are perfect. That's a mnemonic that I can use to, and these are the sites for auscultation of the heart, the valves. This is not where you actually find the actual anatomical location of the valves. It's just where they are best auscultated and also best palpated. So what am I feeling for here? In each of these 4 regions, I'm feeling for bruits, B-R-U-I-T-S, bruits. Bruits are felt as a vibration, just a kind of a vibration sense just under the hand, and that is reflective of turbulence in the blood flow in the area. And the reason you get that turbulence is because of various pathologies, including but not limited to valvular heart disease. And again, that's outside the remit of this video, so I'm not going to discuss that here. But valvular heart disease can be suspected in the presence of bruits. The final thing I'm going to assess for here, I will then place my hand in a direction like so on the patient's sternum, and I'm going to feel for what I call parasternal heave. A heave essentially is where it feels like the heart is pounding into your hand, and again that indicates various forms of cardiac pathology, and again outside the remit of this video, so I'm not going to elaborate too much on that. So there you are, the apex beat in the average healthy male human being, as well as in children, where you might find it pathologically, and when how we assess for bruise and parasternal heave on the back of surface anatomy. Thank you for watching.